Hey everybody, this is Erin Roberts, and the monograph, the topic that I chose is cellulitis. A little bit about me. I've been a certified medical assistant for 10 years, working in clinic settings, so I've seen a lot of cases of varying degrees of cellulitis. It's very common. You are 100% certain to see it in your nursing career multiple times if you haven't already, and that is why I chose this topic. The patient that I saw in the emergency department was a 62-year-old African American male. He has a history of type 2 diabetes and kidney disease. So he arrived at the ER limping, reporting of pain, especially when weight bearing and swelling to his extremity. So when he got back to the exam room, his skin was red, swollen, it was warm to the touch. All of his vital signs were normal. There was no evidence of any systemic infection. He didn't have a fever. His heart rate was normal and his blood pressure was good, but there was slight weeping of his extremity. He reported he noticed itchy bumps 1 week prior, which he scratched and likely is the cause of the cellulitis. There was no culture taken. He was discharged on oral antibiotics and recommended to follow up with his primary care doctor. Cellulitis is an acute and diffuse inflammation of the skin. It's most commonly seen in the lower extremities, and oftentimes it is unilateral, so it affects one leg or the other, or one foot or the other. And it results from a break in the skin. So a bug bite that you scratch, or even like a pimple that you pop, or a cat scratch, these can all lead to cellulitis if the skin is not cleaned thoroughly. And microorganisms invade the breaks in the skin. Primarily, cellulitis is caused by strep, pyrogens, and staph aureus, but other organisms can cause cellulitis. These are just the most common. So this patient did report itching his leg due to some bumps, and potentially there was some maybe poor hygiene involved with this patient. So there was not a culture obtained, but a broad spectrum antibiotic was prescribed for this patient. And if his cellulitis did not improve, likely then a culture would be obtained. Manifestations of cellulitis that the patient did exhibit was warmth to the skin, he had edema, he had pain, he had erythema, and slight weeping of his skin. Some other signs and symptoms, maybe more serious signs, necrosis to the tissue. They can have vesicles, so like kind of pus-filled sacs, get a fever. Significant drainage can occur, and then systemic infections can develop, like leading to sepsis and amputation or even death if it's not treated. Risk factors that this patient demonstrated were diabetes. He had a history of kidney disease. He also had a history of cellulitis, so oftentimes cellulitis can be recurrent, and this was his case. And he had a break in the skin. Other risk factors include advanced age, so your skin obviously loses elasticity and becomes easily damaged. Alcoholism is a risk factor. A weakened immune system, cancer, steroid use, IV drug use, peripheral vascular disease, and malnutrition can all be risk factors for cellulitis. The major goals of managing patients with cellulitis are first and foremost treating the infection. So we do this most often, by prescribing oral or IV antibiotics if the infection is bad enough. We want to manage their pain. We want to prevent a systemic infection, so prevent anything from worsening, and then promote that wound healing. Oftentimes that's done by nutritional support or sterile dressings. And deep vein thrombosis can present like cellulitis, so a lot of times an ultrasound is recommended to be performed to rule out any blood clots. And then in more serious cases, surgery might be required, so debridement of necrotic tissue, a fasciotomy, or even amputation might be necessary. So my first current literature article is Interventions for the Prevention of Recurrent Erysipelas and Cellulitis. It is a level of evidence 1, meaning that it is evidence from a review of randomized controlled trials. So this was a study that included 6 trials with 573 participants. They were between the ages of 50 and 70, so my patient falls into this category. And they all had a history of recurrent episodes of cellulitis. They all had between 1 and 4 recurrent episodes. My patient had a history of recurrent cellulitis. They were either placed on antibiotic therapy, they were placed on a placebo, or they were given no treatment at all. And the conclusion overwhelmingly states that long-term antibiotic treatment is most effective for recurrent cellulitis. So they say up to 2 years is highly effective. But in addition to that, other treatment options are recommended. They include, along with the antibiotic therapy, they talk about skin care education, treatment of edema, so possibly a diuretic needs to be prescribed, weight reduction in an overweight patient, and compression stockings are very effective in preventing cellulitis. The second article for my current literature is Cellulitis and Abscess Management in the Era of Resistance to Antibiotics. It's a level of evidence 7, meaning that it's evidence from the opinion of authoritative reports of expert committees. So to begin the study, these committees developed a documentation tool that was supposed to help providers record all of these elements that the CDC recommends to be documented when treating patients with cellulitis. These recommendations include the appearance of the area, the need for any incision and drainage, whether or not a culture was obtained, and the initial antibiotic of choice, if there was any antibiotic prescribed, along with the rationale for the choice of the antibiotic. 9 primary care practices were involved in this study, and 30 charts per month from each practice was audited, with the median number of months participating being 9. And of the patients who had cultures taken, 56% of them did test positive for MRSA. Commonly, these patients were treated with a broad spectrum antibiotic, and those nearly always cover MRSA, but some patients did require follow-ups because of the lack of improvement in their cellulitis. And so practice follow-up is of the highest importance. So my patient in the ER was given a broad spectrum antibiotic. There was no culture taken, but this antibiotic should have covered MRSA, and the importance of follow-up with his primary care doctor was emphasized to the patient. Evidence-based nursing recommendations for cellulitis include, but are not limited to, physical assessment. So obviously we want to be assessing our patients, so a complete physical assessment to assess for signs and symptoms of cellulitis and systemic infection. So obviously doing a thorough exam of the patient's skin, looking for any areas of pain, redness, and swelling, and then those systemic signs. So if the patient had a fever, an elevated heart rate, or tachypnea, that might indicate a systemic infection. We want to analyze any blood or wound cultures that are performed. In this particular case, the patient did not get a wound culture. However, oftentimes in cellulitis, there is a culture taken to test for MRSA. And we would want to implement any contact precautions and manage the patient's antibiotic therapy. Even maybe if the patient doesn't get tested for MRSA, we maybe want to assume that they have it and just maintain those contact precautions. For discharge, we want to demonstrate wound care techniques for the patient and then assess the patient's ability to perform their own care when they do go home, and then evaluate. So we would hope the patient would exhibit reduction of his symptoms. A lot of times I think an ER evaluation isn't always possible, so that is why we encourage the patient to follow up with their primary care doctor or return to the emergency room if his symptoms do not improve or get worse. Benefits to the patient of student knowledge of cellulitis include early identification. So if a student knows what the common signs and symptoms are of cellulitis and know what they're looking for on an assessment, that redness, pain, swelling, possible weeping of the wound, and that skin that's hot to the touch, then cellulitis can be identified quickly and we can begin treatment sooner. Also understanding that there may need to be a differential diagnosis. So because DVTs and cellulitis have similar symptoms, understanding that we may need to rule out a DVT before assuming that this patient has cellulitis. Also, knowledge of home care of the discharged patient, because these patients eventually will leave the hospital and likely their cellulitis will be 100% resolved. So understanding or being able to educate the patient on dressing changes and, elevating their leg and skincare routines, and then prevention education. So if you have a bug bite, try not to scratch it, or if you have a cat, try to avoid a cat scratch. If there are any bumps or lacerations or scratches, we would want to educate the patient on cleansing these wounds to prevent the cellulitis. And then also those things we talked about earlier, the weight reduction if they're overweight, treatment of edema, and then compression stockings if the patient might need them. In conclusion, cellulitis is a skin infection caused by bacteria. Most often it is caused by strep or staph. It occurs after a break in the skin from a scrape, cut, bite, or puncture, or even after a rash. Cellulitis may be treated without doing any tests to find out what caused it. However, if symptoms persist, do not improve, if they worsen, then a culture may be obtained to check for MRSA. But cellulitis is treated with broad spectrum antibiotics in an attempt to treat MRSA without testing for it in case the patient did in fact have MRSA. However, follow-up care is a key part of treatment because of the chance that the patient could have this antibiotic-resistant infection. So if the patient's symptoms did not improve, definitely if they worsened, or just to be monitored after a serious infection, the patient really needs to follow up with a primary care doctor or even a dermatologist. And that is my presentation on cellulitis.